The topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Good evening, everyone, and welcome to TriVersity Talk. I am Steven Bloomer-T.
And I am Wendy Stewart Kaplan, and thank you once again for joining us on this Thursday night where I am in New York City and there are sirens, as usual, outside my window. It's so darn noisy here, Steven.
Well, these cicadas and crickets, they're just really getting to me.
Don't we have a cicada problem? Aren't they coming or they're there already? What's going on with the cicadas in Pennsylvania?
I never keep up with cicada drama. I just go with the flow. I love the night background noise, whether it's crickets, cicadas, or whatever,
Frogs. We love the tree frogs.
Absolutely.
How's your week this week, Steven?
Oh, it's been pretty good. I had an action-packed day at the center on Tuesday. Had a lot of people come in. And then Thursday, which is our other open day, we celebrated two of our regulars' 45th wedding anniversary.
Wait, that would be Sherry and Nels?
Sherry and Nels, yeah.
Oh, God, okay. Happy anniversary, happy anniversary, happy anniversary. That's really cool. And I love that you mentioned that we're open Tuesday and Thursday and people are coming by. I mean, we're center. That's what we're there for.
Absolutely. Now, one thing I haven't been doing, which I'll do real quick, is to say, if you're watching us on Facebook or YouTube, give us a like, a follow, a love, throw a few comments in there. We really appreciate it. But before we get started, we're going to play a little commercial.
We have a commercial, yes.
Let's do it.
Okay.
Keeping you informed in Thunder Country. Community, diversity, equality. Isn't that what it's all about? I think so. Hi, this is Jonathan Charles Fox, inviting you to join me and Dharma the Wonder Dog, along with special musical guest Chuck Vassallo, for an evening of personal storytelling called Out Loud and Proud. I'm going to be at the Upfront Exhibition Space on Friday, July 23rd at 7 p.m., telling stories about my life. There is no script. There are no rules, and they say it's BYOB, so anything can happen. Out Loud and Proud is a fundraiser specially created to support TriVersity, the Pride Center, and its mission to create a safe space for the Pride community living in and visiting Thunder Country. Seating is limited. Reservations are strongly recommended. Buy your tickets one night only. We'll see you there. Right, Dharma?
Don't miss out on the fun. Get your tickets now before they're all gone. Go to TriVersityCenter.org. That's TriVersityCenter.org.
We are Thunder 102 and 104.5.
Well, that did it a lot easier than I would do it, and it was more fun.
102 and 104.5, and Jonathan Fox. I mean, I love Jonathan to death, you know that, but what a great commercial, Absolutely. Jonathan, scripted, anything can happen.
Amen. And yeah, really looking forward to this. So Wendy, I'm so looking forward to this episode tonight. So I'm ready to.
We are so excited, ladies and gentlemen. Let me see. I was down in Florida when I had a Zoom meeting with these incredible guests that we have tonight. And I love that we were able to make everything come to fruition. From the Mount Sinai Center for Transgender Medicine and Surgery, whose goal is to provide comprehensive and compassionate care to transgender and non-binary individuals. We have with us tonight Dr. Joshua Safer and Matthew Baney. Please welcome. Come on in.
Hi, everybody.
Hey, it's pleased to be here.
Thank you first of all, for being here tonight. Your schedules, I'm sure, are, and you took time out to join us here to share what I feel is very, very important information that, we do a lot in the transgender community. We know many transgender people, but so many people ask us, and Steven will tell you, so many questions, right? That it really takes experts and the people that are doing the work to answer. So we're thrilled to have you here. Thank you so much.
Well, thank you for asking us.
So I'd like to open up tonight with just an overview. I was about to say a brief overview, but nothing can be brief about what you do. But I would like to have an overview as to what goes on at your center.
Odds or evens, Josh? You can go first.
I don't know. Who starts? Exactly.
You go first.
We'll say different things. The idea of our program is to be a single destination for patients who, for any of their healthcare needs, whether they're trans, they think they're trans, they're a parent who has a kid who might be trans or simply gender expansive. And then those individuals should be able to reach out to us, and then we navigate them throughout the Sinai system. Our center isn't literally one location, but it's but we exist everywhere, or many places, I guess I should say, in Mount Sinai, and therefore have available to us adult primary care, adult adolescent medicine support, hormone therapy, endocrinologists, mental health support, and then various surgical procedures that people would want. We have, I think, 11 connected surgeons right now who are part of our program, doing really the whole gamut of gender affirming surgical procedures.
So would you say that Mount Sinai is unique to this? There can't be too many places doing what I would call one-stop shopping.
Well, we're far and away the biggest and most comprehensive program in the world in this space. We started in 2016. Actually, when I say we, it's more Matt than me. I joined the program about a year or so later. But we started the program with really being one of two in this space. The program I come from, Boston University, being the other. We're much larger than that program. Maybe there are about a half a dozen other programs that are trying to put these pieces together. We're unique right now, but we shouldn't be unique. We're really a model, and others should be imitating us. That's some of our agenda.
Yeah, I think that's interesting, Josh. And just if you don't mind me building upon what you just said, this or Wendy, you and Steven, we spoke about this a little bit before. The president of our health system gave this charge to the president of our hospital to create this program. And so just that alone gives you an idea of how much support we get through the Mount Sinai health system to make this happen. I don't know whether that would be the case in other places, but here within Mount Sinai, we get an incredible amount of assistance in what we do. Now, when we were first charged with doing this, and Josh will understand this better than I am, we weren't even sure exactly what was being done in this area across the system because we're just so big. So one of the first things we had to do was kind of take an inventory and throw out a net and say, okay, who's working and doing what? And once we got that together, it was kind of interesting to see that we're already on the road. People were doing their independent things simply because we're so large, you just weren't aware of what was happening. And once we put them all in a room, the program just started to grow and to grow and to grow. And as Josh and I say all the time, we were, as a need is identified by either our patients or by our staff, we look at it, and if you say you need it, Josh says go out and get it, and we go out and get it. So I think that's what makes us so comprehensive. It's consistently changing. It is so fluid. Wouldn't you agree, Josh?
Yeah, absolutely. And we're lucky to be in a place where we are the establishment and we have the capacity to actually provide the care. If you think about it from that, I mean, that's how I think about it anyway. That there's such a need, but we're actually positioned to model how that need should be addressed, and we have the support, like Matt says, from it's almost like a religious zeal with our CEO.
It is.
And the president of our hospital, which really help us in that regard.
Yeah, it's really important for that underscore that we don't have to convince anybody that this is important. They already know, and we don't have to convince other providers, other medical providers, that this is important too, because they already know. And Josh spends a significant amount of his time educating people out within our system of what we do and see what kind of marriages we can make. I don't remember that word, Josh, so sorry about that. I don't remember the word.
Shut up.
There you go. There you go. That's the word. He makes the marriages to make sure that things work out.
It is very, it's interesting what you're outlining here tonight, because the biggest criticism of medicine nowadays, I'm not talking about transgender medicine, but medicine in general, the left hand not telling what the right hand is doing. Like here in America, you have your primary care, and then you have your other doctor that you go to for this, and your other doctor for that. And I just had a friend whose mother passed, and she was in a hospital in Baltimore, 6 different doctors. This woman's a senior, okay, constantly getting a different doctor, right? And nobody talking to each other. And, we hear of this all the time. What you're outlining for me and Steven is something that is so totally supportive and totally different than what a lot of people are used to. Do you think it's got to do with the fact that you have such an incredible president that's totally spot on and wants all of those components to come together?
It's 2 things. Partly yes, but partly because this was a neglected field, we're starting from scratch, and so. If there's a silver lining, and I think there is actually in that regard, we don't have as much problem with entrenched silos in the institution because nobody was doing it. And so when we have people who want to be, when we have people, even if they're out there on their own and they were doing something, they want to be part of the bigger team. And so that lets us do it lets us almost model the way medicine should be delivered in other subjects, where they're a little set in their ways, as it were.
So Josh, I have a question, and Matt too. So you get a patient, and so who's interested in the center. So where do they go? How did they get this process started? And do the dominoes then fall into place after they do some initial, intake?
Right. So no matter what your circumstance, if you are looking for medical support, I mean, we're mostly medical. We have some other support, but mostly it's a medical thing. Then it's kind of low tech right now. We have a phone number. You can Google us, and there we are on the web. Transgender, Mount Sinai, or New York. We'll pop right up, and then. There's our phone number, 212-604-1730. And somebody picks up the phone and they take a message, and then a member of the team will get back to you. And we have a web, what do you call it? An email address where people can call in similarly.
There you go. Email. Yeah.
Exactly. So like I say, pretty low tech.
Right.
But that's the job.
Exactly.
With what you're dealing with, it helps to have it low tech. People wanting to transition go through enough, all right, to get to the point where they pick up that phone and say, hey, tell me about what you do, okay? There's so much misinformation out there. And within people that transition, okay, and this is something I want to talk to you about. I have personally found, I'm sure Steven would agree with this, the needs of somebody in their 20s to be grossly different from the needs of transitioning in their 50s or 60s. Now, from your perspective, you cater to all different age groups?
Yeah, absolutely. The entire lifespan.
The entire span.
And right. And people's needs, it can be different based on age or just because people are so different. And their circumstances are so different. One of the differences, you mentioned the word transition. So some of our patients aren't transitioning because they've always been trans. They just are coming in for their meds. And just right there, these kinds of language, even how people think about things is so different.
Well, I love, when reading about the program, I love the first thing that's talked about is primary care, because that's one of the reasons LGBTQ folks are afraid to go to physicians. It's because they're afraid they won't get gender affirming, or culturally competent care from their physician. So to know that you have one place where you can go even to get your basic care needs is wonderful.
Yeah, huge. Primary care, part of the problem with trans care has been that it was considered a mental health concern. And so people were then being pushed to a mental health, to some sort of a mental health solution when they didn't have a mental health issue. They're trans. They might want some mental health support dealing with circumstances or choices or whatever, but the fundamental situation isn't a mental health concern. And so being able to come to primary care to kind of conventional medicine is where you want to start. And like you said, we're looking to create safe spaces. So, and actually right now we're talking about the center, but honestly, the goal is to get to a place where anywhere in Sinai is a safe place. And I can't say that we're there yet, but we have a little bit of a step approach. Now you come to us, or I've said already that we have providers located throughout the Sinai system. So we have our champions, and our goal. I'll call it a goal. It's not. It's more than aspirational. We'll get there. Is you should see our logo, and it should mean that that's a safe space, and then others should be imitating us and doing the same thing in their systems. We're not there yet.
Idea of the logo, defining that it's a safe space. That's actually brilliant.
Working on that a lot. Also, if you don't mind, I just want to build on something you said too, Josh, which is we're consistently looking at the patient experience, and it's a work in progress. And I wouldn't say that everything is perfect, because I don't think anything in the world is perfect. And I think there's always room for improvement, and everything is a learning opportunity. And we're taking feedback that we get from our patients and changing the program as best we can to be even more engaging, inviting, and welcoming. This has been a focus for us for a while, and Josh has moved it to the forefront now because we've got a fairly strong, solid base. Now let's look at our other pieces of our program. One of them is to make sure that experience is as great as it can possibly be. And so we're getting there. I think that's fair to say.
I agree. And Matt makes a very good point. Right. You want to have, just because we're safe, that's not enough. It also has to actually be patient friendly, just at the same level as anyone else. And even another piece, which we're not even saying, but I have to say this out loud, is we need the quality to be high. That's another gap in care. You can find some safe spaces where where it's you're not always sure that you have the best providers, and so that's another that's another thing. Safe is not enough.
You can have their pronouns, but could still be clueless about providing.
Exactly. Josh, we're on the same page. Exactly.
Right. That is a really good point. I would like to go back to what Steven said in the very beginning about let's start with where you start, right? Do you start with an evaluation of the person because you do offer so much? Where do you start when someone comes in?
So it's variable because people come in from so many different places. So it depends who you are. We have people coming in just looking for primary care. I have, some kid in tech who comes and moves to Queens and says, I'm looking for primary care, and somebody who can keep my refills going. There's no evaluation. It's like, sure, let's hook you up. I have somebody who's already in care, maybe somewhere else, even in New York, or maybe from another state, who has heard that our surgeons are especially good at what they do, and looking for a specific surgeon with a specific surgical procedure, whatever it might be, genital surgery or facial feminization surgery or what have you. And that person reaches out, and we're going to then work, it depends on the surgery, look at, let's say, readiness and facilitate their surgery. Some surgeries are more complicated and we need to work on them a little more. Some are more simpler in terms of what we need from the patient, and they just pretty much have to show up. That's on the one hand, and on the other hand, we'll have parents showing up or with a kid who's gender expansive, and then that's all about the evaluation. That's all going to be about the intake and trying to figure out what's going on, and having some and providing some support to the parents so they do the right thing with their child, as well as the child being able to safely think through both issues with regard to gender identity and then what it is that they want to do about it, independent of what their gender identity is.
Could I build on that just a second with one other piece, Josh? One of the challenges I think in my head, and some of my friends who've come through, has been that they wonder if they have to break their relationship with their existing doctor to start working with us. And that's not the case at all. I mean, we make it really, really clear. We do. If you have a relationship with a primary care physician or whoever it is out in the community, and you're happy there, we don't want to take you away from that. We want to supplement that and come on over to us. We'll help with you the pieces that we can do, and then we send you back in partnership with your provider. But we don't ever want anyone to think that they have to break off or in any way separate from what they're doing right now, because it's working for them. And so we want to partner with all those other practitioners in the community. I think that's important to put out there because it does become a question.
Yeah, Matt makes an enormous point there, which is we do whatever you need. We can we can help you educate your primary care provider. That shouldn't be your job as a patient. That's a complaint of some of our patients, and we could do that. And we can provide programming for them, or you might have a primary care provider who's just not comfortable with the hormone regimens. We can help you with an endocrinologist and then get you back to your primary care provider, like Matt said, or surgeries or whatever it is. We can be comprehensive, but we can fit around your existing healthcare people who you like and help bring them up to speed for you.
I love that you talk about the willingness to kind of teach or advocate for patients with their primary care physicians to teach them things they might not need to know. I mean, I hear two reasons that, again, LGBTQ folks would avoid going to a doctor, and one is, insurance issues, but the second is just being afraid that you're going to be marginalized. So what you're doing is incredible.
Yeah, I was looking recently at the stats, and the latest study I saw is like 700,000 self-identified LGBTQAI individuals in New York City. And out of that, about 26% of them are not in any form of primary care at all. And then there's a larger percentage who are, but they don't feel that they're getting culturally and competent care based on being a member of the community. So there's a whole population out there that's not even been tapped yet, and they need services.
I think you brought up a really good point. Josh, you mentioned before, some people come in, they're not coming to transition, they're just coming to get the hormones and no evaluation. And I thought, isn't that fantastic? Because 5 years ago in Pennsylvania, I knew people that were going and getting, I don't know what to call them, over-the-counter or under-the-counter or the black market hormones, okay, because they didn't have a doctor. They couldn't get anyone to see them. And I don't have to tell you the damage it can do to a person when your hormones aren't measured, your blood levels, none of the medical stuff is being done. You're just getting hormones. I love that you will just address hormones for people because as Steven and I have learned, and this was an eye-opener for me. I know so much, and yet sometimes I feel like I know so little. We had Julie Gray Owens on the show, and she talked about people that transition. Some just get hormones. Some take what you call the train all the way to Montauk, And I think that's a great analogy. I never thought of it that way, and people don't. Some go all the way to Montauk. Some only go halfway. They may get off in Huntington. Okay.
Bayshore.
Stayville. To have this discussion and to put this out to the audience out there, it's really important to realize that you guys are addressing every level of it for a person. It really is comprehensive care, and I so admire what they're doing at Mount Sinai. I wish there were, I love that you're a model, and I hope more places around the country start to follow it. We need it.
Yeah, and what you're suggesting too, it's not just that people go to different degrees along some single path. It's not even linear.
Right.
So, people have different needs. I have transgender women who are who are looking for a facial feminization surgery, but they're not looking to have genital reconstruction. Yes. And alternatively, and it depends where they are in life and who your intimate partners are. And, there are just so many things that make these things so personal. And like you said, you could have hormones or hormones to a certain level, because the hormones do a certain thing to you, and you don't want like the full dose. And whatever it is, we customize. We're the medical people, and we think about what's safe. And so we try to help patients from that perspective. We don't want to do things that are unsafe. But then beyond that, we're very mindful of the fact that there are as many permutations as there are people.
Yeah, there are. Right.
An interesting point too, Josh, to bring up that just to add, this is for Steven and Wendy. Our program, when we first started, one of the things we thought was the most important to include right from the start was an insurance specialist.
Yeah. Oh.
Someone who can help with a patient understanding what's covered and what's not covered. If we have, and Josh is better at this, way better at this than I am, arguing things as far as what's medical necessity and what's not, because those arguments still take place, even though the world has changed, we still have those issues. So with these kind of people on staff, we can help the patient get to the next step as far as we can and help them access what they want to access with as much coverage as we possibly can. And we will go to bat with them to fight these arguments. I mean, Josh, you want to add on that? Because I know you're very, very much involved.
Yeah, I mean, we fight that battle at multiple levels. So there's the personal level. Often it's with surgeries and things because that's what's expensive, and that's where you get the most pushback from payers. And so there is some negotiation at that level, and then there are the long haul battles where we have work to do, and we haven't won them all by any stretch, where we're simply, things like facial feminization surgery for a transgender woman who's had a lot of testosterone exposure to her features over the years before she started to get into treatment is absolutely necessary for comfort and for safety. But if you only look at things through the lens of a cisgender person, then you're thinking, oh, well, that's just cosmetic. And so a lot of the insurance companies are designed still with that cosmetic framework. And
I ask you, because you're the person dealing with this, what kind of strategy do you use to get around it? Because you can just see, you just brought up a good point. Some cisgender person sitting in an office, oh no, this is a cosmetic procedure. Like having absolutely no empathy for the person that absolutely needs to have this so that they can have a good life.
Yeah. So part of what it's education. It's education, and education comes from several different directions. So we can have data, and sometimes it's just a matter of having some credibility. And this gets back to we're lucky to be the establishment. Yeah. Is when we go and say we're Mount Sinai Hospital and this is the truth. We do. There's still a lot of bureaucracy and a lot of inertia. So I don't want to overstate that. But the providers take us seriously. They say, well, what's the truth? You wearing the white coat with the Mount Sinai label, people, and we can do that for in the field.
Yeah, I think also, Josh, which is something just recently came up, where we're partnering with insurance companies to go up to Albany and to the insurance plans to say you're not paying enough to cover the service that the people need, so that's not good. And also, as Josh would say, medically, it's necessary. And so if we kind of do advocacy in a couple of different ways with different partners, then nobody would expect that we'd all be in the same room at the same time, arguing for the same thing. And it actually is where we are. We are all together arguing for the patient. And I think that's a unique thing that we're trying to accomplish now as well.
So when So when talking about medical necessity, are we also talking about potentially physical safety? And the reason I asked you this question was I heard a story today. One of my friends who is trans, she was at like a festival or carnival or something. Someone knew she was trans and spoke to others saying, here's somebody who's trans, you'll know because of her voice. And I'm sure there was misgendering going on. But so it's like voice feminization surgery could actually protect you physically, make you physically safer if somebody couldn't identify you based off of your voice.
Yeah, absolutely. And there are multiple levels in terms of what the actual interventions are, from simply a speech pathology to surgeries. There's the whole range there, and we have all of that. I'm not, I'm a medicine doctor. I'm an endocrinologist by training, and so actually I don't rush to my training is not to rush to surgery. It's like, well, let's try medicine a little bit. Let's see how it goes. That's just in that pathway. And for voice, it's very much that, at least for openers, getting comfort with your own voice and do it, using the correct speech patterns and things like that. And you're absolutely right. It's a matter of comfort and it's a matter of safety. And it has to be a priority for some people, and the payers have to recognize that it's medically necessary.
I actually got a question from somebody from the court, Dolores Degade, who's a wonderful performer. She would like to have her voice worked on. Her fear, her apprehension is she's a singer. So the question I wanted to ask you is, from your experience, how does it affect the singing voice?
Yeah. So you have to bring in our voice, our voice surgeon in the therapy group sometime too to your show and get really detailed and have some call in there. But yeah, it's a fear, and so that's there's a tension, and again, this is some of the logic pattern of why we want to be in this space.
That they'll be have a singing voice when you know what I'm saying. A person that's an entertainer, sure. That's a biggie.
Yeah. I don't have a magical answer there. So, and part of my answer then is, that's a reason why you have to you have to be thoughtful about that. And here too, I like our position as an academic medical center. We're going to try to think what's going to be best for you, and not necessarily try to quote unquote sell you something, like a surgery that might actually make some money for the institution, but might be the wrong thing for somebody in that circumstance where maybe they need to back off.
Or just have vocal coaching, which you talk
instead. Exactly.
Yeah. Right.
Don't go for the medical solution. Yeah.
It would be totally less invasive. So can we talk about some of the procedures? I don't know, I'm going to use, this is the wrong word, basic procedures that you perform for people that are female to male, male to female. And if you can do it according to, because I learned a lot, somebody we know over 50 explained to me the different kind of vaginal surgeries, as well as if you have a certain body weight and certain medical conditions and you're limited. Could you discuss that a little bit?
Let me just outline it, and then you'll see where you want to say. So for transgender women, for trans feminine folks, the surgical options in my brain anyway are kind of divided into three categories: facial feminization surgeries, and we can talk about the specifics there; breast augmentation, which is what it sounds like, and then genital reconstruction surgeries, which are pretty much just vaginoplasty. And there's a range. Kind of the gold standard is penile inversion, which is literally taking the penis and making it inside out and trying to leave everything hooked up, so that depending upon a person's interest, the appearance is good, and function is good. And what do we mean by function? That you pee normally, you sit down and it's not a total mess, and you can have penetrative sexual intercourse if that's an interest, and you're orgasmic because the nerves are still hooked up, and so that's that category. Those are the three categories of surgeries on the trans feminine side, and on a masculinizing side, I guess there are kind of two. There is facial surgery, but there's much less need for it. A thing, we have a lot of biases in society, and when we live in the trans world, we see some of those biases. And one of those biases is we're very particular about what constitutes a female face, and pretty much everything else is male. So your trans guys, they get a little testosterone, a hair appears on their cheek, all of a sudden they're quote unquote passing because that's male. And so there's not as much need for a surgery there. Also, testosterone adds features. So if you come to this later, you've had testosterone exposure, you have these features to your face that just aren't there if you're a trans guy, female to male. And it doesn't matter if you add them a little later. And again, with our societal bias, even if you're a little older, you appear, you're a transgender guy now, you have a hormone impact. Maybe you look a little younger, but in society, we actually like that. And so there's just less demand for the surgeries up in the face.
How much had to do with the way society, right, looks at somebody. You're right. And that's a totally superficial criteria. But you're right. If you pass, you pass.
It's just what it is. Or what it is in the current universe with our current biases in our society, because other societies have slightly different biases. The chest surgeries, though, big deal for the trans guys. Majority of them overwhelming majority are looking for them. Just chest masculinization, relatively straightforward surgery conceptually. And then we have the genital reconstruction surgeries, and there are kind of two flavors there, relating in part to the fact that those surgeries are less well established than the vaginoplasty. So we're not as, we don't really have the skill set yet to take, let's say, basically take tissue from elsewhere for a phalloplasty for the creation of a penis. And we don't really have the techniques to make something that's, let's say, going to have erections or that's going to have sensation in the correct locations. And so a little bit more of a fraught surgery. The biggest bugaboo actually is if you want to pee standing up, extending the urethra, where you're peeing through, that tissue, our ability to recreate things or extend that is just nowhere near what God could do. And so those people get scars and those things close suddenly and they're subject to additional surgeries. So that's actually a bit of a problem. And so we have kind of an in-between surgery called metoidioplasty, where we take advantage of the fact that testosterone action on those parts of the body does try to already change them. Your body, it has the cells, it has the tissue, and so what we call a clitoris in a woman, you put a bunch of testosterone, it starts to want to grow into a penis, and so that happens to some degree. We can free it up a little bit by cutting some of the skin in the area, and just it's going to be a small penis if you only start it later in life. But we can make it a little bit larger, and that's more or less what metoidioplasty is. So those are kind of the categories.
So we had another guest on a while ago, Holly Lorca, who works at a facility in Austin, Texas, and she talked about a vulvoplasty, which, as she said, she's a comedian, the car can't go into the garage. So is that an option at Mount Sinai?
Yeah, absolutely. So that's basically having something where the appearance for the vagina looks it looks from the outside all the same, and you can maintain sensation too. So you can, the clitoris that you create can be also maintained, same logic as with the more conventional vaginoplasty, and especially for people who are older, who are, I said before that different surgeries require different degrees of participation by the patient. And vaginoplasty, it's kind of the classic where I think of it as like a pierced ear, kind of a funny pierced ear, but you have to put something in it with some frequency in order to maintain it. Yeah. And so we have these, basically these plastic dilation tubes that people have to put in. Yeah. And so you have to do that. And if you're not in a position to be able to do that, whether it's for medical reasons or whatever, this vulvoplasty is something that you could consider.
Could I ask you a question, Josh? Two things. The first one is, do you want to touch a little bit on revisions, because that does take place. And
because I know people that have had revisions. I'd like to talk about.
Yeah. I want to hear a little bit about revisions. And the other question that I thought the audience might find interesting, when we talk about some things that could be barriers along the way, smoking or BMI or whatever, I know they change all the time. And maybe you wanted to talk a little bit about that, because that's not even right anymore. So you could maybe help us with that.
Yeah, absolutely. So revisions. So I kind of divide revisions into maybe about 2 or 3 categories. And so the first is to recognize that that some revisions are going to happen anyway as kind of par for the course based on how you heal. And so any patient, and again, depending upon the surgery, but let's talk about vaginoplasty, because it's mostly relating to the genital reconstruction surgeries, with vaginoplasty being more common than phalloplasty. And so with vaginoplasty, you do a certain surgery and then you see how it heals. And in the plastic surgery world, it's not uncommon at 6 or 12 months to have somebody come back and have a little bit and have things adjusted a little bit, as it were. It's kind of funny to talk to my surgery colleagues, because they treat people almost like you're pieces of cloth and they're tailors. And they're like, oh, we'll just take a little more off. And
a little off the top. Yeah.
Exactly.
That's to do with how a person heals. You can't really predict the outcome.
Exactly.
That's how a person heals.
Exactly. And so you're going to have that. And the most important thing is you don't want a surgery where there's an injury from which you cannot recover. So, for example, a complication like a nerve damage, that has to be a never event. Okay, that can't happen. That does exist, but that's a different category of event, where a revision like I'm describing, because let's say the clitoris that got created is a little larger, it didn't heal as small as the patient was expecting. And so they want it taken down a little bit more, or actually any direction, so long as all the nerves are intact.
So it's not uncommon. It's not necessarily uncommon for revisions.
It's not uncommon.
Yeah.
And in our group, we do revisions from other surgeons where people have had to travel long distances, and so they're not able to even get back to those surgeons. It's not even a ding on those surgeons. And sometimes the patients are a little bit confused, and they are thinking it's a ding on the surgeon because they, something healed a little differently than they expected, but they shouldn't think that. That this happens, anywhere from 10 to 20% of the time, just depending upon how people heal.
The more both of you talk, the more the question comes to me: what are we doing about educating people, educating doctors? I think where the things are coming apart is, for me, and what I hear, is a lack of communication and education out there. What programs are existing that are going to move things forward in the way that you're doing it in Mount Sinai?
I guess, there are multiple levels, so I might have to ask what you mean. That is, we need to be more intentional about teaching this stuff right away in medical school.
That is what I mean.
Yeah, there is a big gap. We're part of the, it's kind of ironic, but part of the problem is very well-intentioned people put trans care along with other LGB care, and T on the end, and so some good sensitivity and good understanding of how people live their lives is what that's about. But it doesn't teach you some of the specific interventions that you need to know, and so so that's like an extra piece that really has to be included. And even the very well-intentioned medical schools across the United States are still not good at intentionally including that as part of their curricula.
Do you feel like in other places in the world where they are more advanced? I would be curious. I don't know what goes on in other places.
Oh no, we're this is America. On this subject, Donald Trump is right. So
and that's it. That's absolutely it.
That's it.
It's right. Right.
No, it was the case. The Netherlands was ahead of us. That is, they've been more appropriately treating trans patients in their healthcare system for, let's say, 30 or 40 years. And we're late to the game, as it were, in that regard. Belgium, the Dutch parts of Belgium, anyway, same. That's really the only example.
What about Thailand? I heard the surgery in Thailand, they do a beautiful job, especially with the cosmetic facial feminization surgery.
Yeah, so Thailand's a funny story. So Thailand has great surgeons across all care, and it's kind of a destination surgery place for affluent outsiders, not for Thai people. So it's a cash basis. It's much cheaper than in the West. So in an era when people had to pay out of pocket instead of using the greater insurance pool, then you could save a buck by going to Thailand, a big buck. But if you were Thai, you weren't part of that.
You're not part of that. So it's really for foreigners. I got to tell you, the boobs that I've seen have come out of there. I'm ready to take.
Well, right.
I knew I loved you, Wendy.
So
no, seriously, the boob jobs here just don't. That I've seen, they don't compare to what you can get.
They are some great. It's very true.
They're natural. They're just beautiful.
Yeah.
If there's one takeaway from tonight.
Exactly.
But along those lines, while we're on boobs, because I promised Dolores I would ask this question. What do you think of breast implants versus fat transfer or hormones for breast growth? She wanted to know about that.
Yeah, so I don't know if I can answer that completely because I'm not the surgeon. So the medicine doc in me always wants you not to do surgery and wants you just to take the body that God and hormones gave you. But then beyond that, I can't do a competent job. You'd have to bring one of my surgical colleagues to talk about the pros and cons of the implants versus other strategies. The implants are a little bit more, how shall I put this? A little bit more idiot-proof. In this, and I don't mean the surgeon's the idiot or the patient, but just how you heal. So that's that's going to favor them. The flip side is, anytime you put a foreign, you put something that's not your natural body in you, you're setting yourself up a little bit more for risks for infection and such. So there's some of the trade-offs. But again, more nuance, going to have to go to one of my surgical colleagues.
Yeah, no, Wendy, by the way, for you and Steven, I would say if that was something that you wanted us to explore for you and maybe get one of our surgeons,
I think that would be
surgeons, we'll talk about it and we'll set something up for another one of your shows because I know they would be very interested in doing this. They love to talk about what they do and also to educate the population. They really do.
Wanting that information out there, it's really important. I mean, we've talked about so much, and you both know we've barely scratched the surface. I had pages full of questions tonight, and we've really cut through a lot of it.
And so, Matt and Josh, thank you so much for being on.
Thank you guys so much. Don't jump off, because when the broadcast ends, I take a picture.
Good. Thank you much.
Okay. Thank you for having us.
Thank you.
Thank you, and good night, everyone.
Good night, everyone.